Welcome everyone. Let's talk about orthopedic emergencies. We want to cover most of the orthopedic problems and soft tissue injuries coming to the emergency department. Let's start with some descriptive terms for fracture. We have simple fracture. Simple fracture is when the fracture runs circumferentially and there is only two fragments of the bone. We have transverse fracture in which the angle of the fracture is 90 degrees to each other and the patient is the fracture is not displaced from each other. We have comminuted fracture in which more than one fragment, so one fragment, two fragment, three fragment, four, so more than two fragments are there in comminuted fracture. We have oblique fracture in which more than 30-degree angle is formed. We have spiral fracture in which two fragments of the bone are rotated against each other during the fracture. So we have also impaction. Impacted, what's impaction? When two bony fragments are going into each other, impacted, and the two fragments is leading to driving into each other and lead to shortening. We have displacement and angulation. The displacement describes how bone ends have shifted relative to one another. So for example, how much the distal part is displaced from that part is called displacement. Angulation, how much that distal part angulated relative to the other part. And we have also rotation when one part of the bone is rotating against or rotates in a direction relative to the other bone. Shortening usually happening from the impaction of the bone and from effects of the muscle. We have green stick fracture. Green stick fracture usually occur in young bone. The bone bends and only partially breaks. There is one cortex remains normal and the other cortex is fractured. We have buccal fracture. The fractures result from the impaction causing kinking of the cortex. A kinking of the cortex will happen. These patients do not need to return to orthopedician. You just backslap them and after 2 weeks you remove the backslap. We have avulsion fracture in which there is a sudden muscular contraction which avulses. It is bony attachment. So for fracture stabilization emergency department, does the backslap needed or not? So backslap is needed for fractures to stabilize, but sometimes there are some simple things that does not need backslap. It just needs stabilization by simple bandaging. How many layers of so backslap is usually done by plaster of Paris. We mean by backslap in our locality just to put the POP on one side of the body part, not circumferentially, because during the early days there will be swelling of the fractured part. If it is a complete POP, it will lead to narrowing of that area and lead to complications. For the backslap, for upper limb needs more layers of plaster of Paris. It needs 10 to 12 layers. For the lower limb, it needs 12 to 14 layers. Is it above the joint or below the joint? If the fracture is near the joint, it needs to only involve one joint. So the backslap is from here up to here, does not need to include the for example, in this patient does not need to include the elbow joint. This fracture occurring from the shaft or from the center. It needs to involve the backslap needs to be involved one joint above and one joint below. So you say to involve both joints. This patient have only fracture of distal part of the tibia, so only below the knee back slab. This is the shaft, so it needs to involve this joint and a joint below above, which is the knee joint, so above the knee back slab. You have to when put the bandage on the patient, it should not be too loose, it should not be too tight. If it is too loose, the fracture will not heal appropriately. If it is too tight, it leads to damage and necrosis of the tissues which are on the bony prominence and leads to these complications. For the follow-up visits after back slap, most of the literature say the patient should return after 2 weeks. But for confirmation of the fracture, and if there is a fracture that is wrongly diagnosed or needs more intervention, you have to tell the patient to return to the consultation after 1 week. This 1 week in order, because before 1 week and in 1 week, the fracture is not healed too much, and you can manipulate somewhat. There are other methods for temporary stabilization. Example, for a femoral fracture, femoral shaft fracture needs skin traction, and also sometimes you may put the patient in that device which is called Thomas splint. So it immobilizes compound fractures of the femur and also the knee joint. If you have a skin traction and you need to put a weight on the patient, you have to put 1 kilogram for every 10 kilogram of the patient's weight. Maximum is 5 kilogram. You do not put more than 5 kilogram on any patient. We have other types for femoral fracture stabilization called Kendrick splint. Upper limb injury. Let's talk about some upper limb injury, starting from some descriptive terms. For example, if anything near to the body, you have to say this is proximal. Anything in relation is more to the periphery is called distal. Anything going to the outer side of the body is not called outer, it's called radial. Anything to the inner side, call it ulnar. And of course, inside when you talk about the posterior part of the hand, it is called dorsal. When it is inside the palm, it is called palmar. For tendon injuries, we have extensor. The extensor tendons are on the posterior or on the dorsal part of the hand. If it is more than 50% or complete division, you need a repair, so send for plastic surgeon. But flexor tendons, in any degree, it needs repair because it's needed for more meticulous movement of the hand. For the nerve injuries, even if it is delayed for up to 2 weeks, it can still be quite successfully repaired. But if you suspect, you have to send the patient early. Fat pad amputations, if a finger pad amputation, if a finger pad amputated and it is less than 1 centimeter cubic and without bony prominence, then you can just suture it. But if it is more than 1 centimeter, it needs skin flap by hand surgeon. The degloving injury, when a part of the skin completely removed after an injury, this patient needs appropriate cleaning, washing, and then antibiotic, and then anti-tetanus, and covering with a sterile thing, and then send the patient for the plastic surgeon. We have some simple things like nail fold lacerations. If the nail fold laceration extending toward the nail bed, at that time it needs that you have to give a good pain management, give ring block to the patient. So you give anesthesia on both sides of the finger, and then you remove that nail bed and suture it up. If there is a foreign body under the nail, you have to do a ring block, then cut appropriate piece of nail and remove the foreign body. If there is subungual hematoma, what is subungual hematoma? When there is collection of blood under the skin. If it is within the 48 hour in which the blood still is soft and more than 50% involved, trephine the nail, put a so insert a needle inside the finger and the blood will be coming out. If it is more than 48 hours, because it becomes hematoma, so that's why it needs incision and drainage by the orthopedician or by any other physician. We have also high pressure injuries which occur in some painting companies, painting factories or washing companies, in which the paint or the water comes in a very high pressure to the soft tissue. So if you face across such a injury, you have to give painkiller, anti-tetanus, antibiotic, and send the patient for the hand surgeon or for the plastic. We have mallet finger. In mallet finger, deformity happens like that. Mallet finger deformity, the extensor tendon at the distal phalanx or the tip of the finger is injured. Specifically, it is the tendon that helps straightening of the fingertip. When this tendon is damaged or torn, the fingertip drops and can't be actively extended, causing the characteristic mallet finger, mallet shape. So the treatment is putting the finger in a mallet splint for 6 weeks. You have not to remove this at any time, then the patient will improve. For fractures of the proximal and middle phalangeal fractures, if it is undisplaced, if it is not displaced, just do a neighbor strapping. I mean, if this is the fractured finger, also involve the other normal finger and do a neighbor strapping, and that's all. If it is angulated like that, try to reduce it, then maintain reduction using a neighbor strapping and a volar POP. Volar, it means at that side. Some people, they may need wiring of that by operation. Coming to metacarpal fracture. So these are metacarpals. We have ring, middle, and index metacarpals. If they have no rotational deformity, just put them in the volar slab POP. What is rotational deformity? Ask the patient to make a fist. The direction of all the fingers should point to one point. But if the direction of the fingers are to one point and one finger directed to another area, as in this example, then you have to refer the patient for operation. Refer the patient for orthopedic or to the plastic surgeon. For phalangeal dislocation, you have to do digital block. What is digital block? When you give anesthesia, local anesthesia, to both sides of the finger to anesthetize that part, that finger, then reduce the fracture, then do a check x-ray whether the displacement reduced or not. Then you have to do body strapping like that and refer to the hand surgeon. Why you refer to the hand surgeon? Because of the ligamentous injury around the injury. Coming to the little or fifth metacarpal fracture. For the little finger, it has a metacarpus. If this metacarpal head is fractured, the commonest mechanism is due to punching. Always ask about the fighting. They have a medical legal background. In these patients, it just need a back slap. But if there is rotational deformity, or there is angulation more than 40 degree, you have to send for the surgery. Warn the patient that the fifth knuckle will be shorter than before, even after treatment. So this is the fifth metacarpal fracture, called boxer fracture. It needs that type of back slap, which is called cobra. Let's come to little fifth metacarpal dislocation. Usually, if you look for such an X-ray, you may say this is normal. I cannot see any abnormality. But when the patient is having pain and swelling at that side, you have to be careful. Usually, if it is normal, if you take an imaginary line, all the lines will cross each other. But in dislocation of the fifth metacarpal, what happens is that so these lines will intersect each other, but this one is different. So this line will be different. So you can recognize that there is dislocation of the fifth metacarpal bone. It may be associated with a fracture. You can reduce it by yourself and then splint it. If not, just refer for reduction and internal fixation by the hand surgeon. We have gamekeeper's thumb. Gamekeeper's thumb sometimes is associated with avulsion fracture. It's also known as skier's thumb. Occurs due to injury to the ulnar collateral ligamental injury of the thumb. That ligament is typically injured when there is forceful abduction of the or outward pulling of the thumb, often caused by a fall when the thumb is caught or bent backward, like holding onto a sky pole or during sports. For splinting that one, the thumb spica should be used. Call it thumb spica splint. It immobilizes the thumb and provides support to the ulnar collateral ligament, allowing it to heal while still allowing some wrist movement. So, but if there is a bony fragment avulsion and the displacement more than 2 millimeters, you have to refer for open reduction and internal fixation. If not, scaphoid POP. If not, just as we said, scaphoid POP, or call it thumb spica splint is used, and then refer to the fracture clinic after 2 weeks. For thumb dislocations, it's usually caused by a fall onto the thumb or hyperextension injury. There will be interphalangeal joint or carpometacarpal carpophalangeal joint dislocation. So reduce the dislocation by traction and scaphoid POP. Don't do digital block here. Don't do digital ring block. Instead, you may do median or radial nerve block or give appropriate anesthesia to the patient or pain management. Sometimes there is fracture through the base of the first metacarpal joint. So fracture like this and displacement, call it Bennett's fracture dislocation. The injury results from a fall onto a thumb or from the fall or blow onto a fist that's closed around the thumb. So if it is displaced, send for surgical correction. If not displaced, just a thumb spica or Bennett's type POP is used in order to heal that fracture. One of the common unrecognized injuries to the wrist is scaphoid lunate dislocation. So this is scaphoid bone and this is lunate. Usually there is no space much between them, but if the space between them increases more than 3 millimeter, there will be widening of this space and leads to ligamentous rupture. It is also known as Terry Thomas sign, and so also called Madonna sign, David Letterman sign. Such patients just put them in a gutter splint and then refer them for the plastic or orthopedician in order to do definitive management, which is usually operation. Pulp infections, when there is foreign body or when there is osteomyelitis of the bone, do an x-ray. So if you suspect this, do an x-ray. Then you may do a local anesthesia digital block and incise the pointing area and send the pulse for bacteriology and apply the dressing, commence oral antibiotic. Then arrange and follow up. This can be done in the emergency department by the orthopedic physician or the plastic surgeon. And coming to the paronychia, infection of the nail fold. So for the paronychia, you can do local anesthesia digital block and drain it, but do not give antibiotic, do not need it only if you have cellulitis or the patient is immunocompromised or having diabetes. Coming to another presentation called pyogenic flexor tenosynovitis. Pyogenic flexor tenosynovitis, usually the flexor tendons in the hand, they have some sheaths. These sheaths covering the flexor tendons can be infected, and if they infected, especially those on the thumb and on little finger, it can lead to, because that of the thumb and little finger have direct communication with that of the forearm, it leads to spreading of the infection. How to recognize that if a patient is having pyogenic flexor tenosynovitis? By having Canavel sign. So what are these features? There will be tenderness over the flexor tendon. There is symmetrical swelling. There is symmetrical swelling of the finger. The hand is kept in flexion. If you do passive extension of the finger, it leads to extreme pain. The management is pain management, tetanus, antibiotic, and refer for incision and drainage, and some of them for irrigation under the plastic surgeon's treatment. Let's come to scaphoid fracture. Scaphoid fracture is very common, but not all of them can be discovered by X-ray. So you have to do a proper clinical examination of the patient. There will be tenderness on the anatomical snuff box. So this tenderness also associated with swelling around there will be swelling around the anatomical snuff box, tenderness over the scaphoid tuberosity, over the dorsum of the scaphoid. There will be pain. There will be pain when telescoping the hand, telescoping the thumb. There will be pain on flexion and ulnar division of the wrist. So if the fracture is not confirmed on the X-ray, just do a wrist splint or a plaster or a back slab, then follow up after 10 to 14 days to the orthopedician. They re-examine the patient. They may do an MRI to confirm. If it is confirmed in the emergency department, just do a scaphoid plaster and refer to the orthopedician. There are a lot of complications. The most common are non-union, avascular necrosis because of specific blood supply, and also osteoarthritis later on. Coming to lunate dislocation. The lunate dislocates after a heavy mechanism. For example, a fall onto an outstretched hand with the wrist extended and in dorsiflexion. This force can disrupt the ligaments around the lunate, causing it to dislocate, and sometimes it rotates. Lunate dislocations are serious injuries. They require proper treatment to avoid complications. Usually it leads to median nerve paresthesia. Median nerve paresthesia, in which the thumb and index and middle finger are having paresthesia. Normally, the radius, the lunate, and the scaphoid are in a straight line. If there is displacement, you will lose that integrity. So especially on lateral view, you can see that the lunate is dislocated. As we said, the complication is median nerve injury. Sometimes it leads to avascular necrosis and also complex regional pain syndrome. You have to put the patient on a long arm back slap and then refer to orthopedic reduction. It's a very painful. Dislocation, so you have to give appropriate painkiller. Perilunate dislocation. Here in this patient, radius and lunate are in straight line, but around it the capitate is dislocated like this. So this is the lunate and the capitate is dislocated. So you have to give a good analgesia, splint it, and the reduction should be done by the orthopedic team. Coming to Colles fracture. In Colles fracture, there is posterior and radial displacement. You can say dorsal and radial displacement of the distal fragment. So there will be also, because of impaction of the bone into each other, there will be shortening of that part of the radius relative to the ulna. What you do, you have to reduce it in the emergency department under hematoma block. In hematoma block, and 1% lidocaine, you have to give 5 to 7 ml of 1% lidocaine directly on the palmar aspect of the fractured side. You go under negative pressure until you aspirate blood. Once you aspirate blood, you have to push the lidocaine and anesthetize that area well before reduction. And then after that, do a check X-ray, and as we said, put the patient in a below elbow hand back slap, then follow up after 2 weeks. How to reduce it, I will show you a video which is on the YouTube.
So he has a distal radius fracture. If it's a typical Colles fracture, it's dorsally displaced. If it's dorsally, you'll feel the step. Take his normal wrist and just feel what normal anatomy is like, because this is what you want to recreate afterwards. And when you see this step deformity, you can actually also feel his radial styloid, his ulnar styloid. You'll see if it's shortened. Start to feel what normal is like. And then before you get started, just see how loose the wrist is, and you'll see it's actually fairly tight. His wrist is moving, but the fracture itself is fairly snug. And this is how you know. Once you've tractioned it, you'll know it's loose. So with your trusty assistant, and you're just grabbing on the one side, I put both my thumbs on either side of his distal radius on Lister's tubercle, index fingers on the palmar side, and I'm just water skiing. If this is done under hematoma block, I'll be talking to him about trying to relax his muscles. Just if he's relaxed, it allows me to open this up. If it's done under procedural sedation and he's pretty deep, we don't need to do so much of it. And then I'm just slowly moving it around. And you actually just make little circles and free up the distal fragment. You'll feel that it's loose. You're unlocking it. And now that we've done the traction, we do the reduction. So what does the reduction involve? Pushing down to increase the deformity. Pull my elbows in towards me, and I bring it down, and I reduce the distal radius. Now, it's also impacted radially, so it's ultimately deviated. And when you have it ultimately deviated, you'll feel that the radial styloid is past. The ulnar styloid, it's moved out. You'll actually feel with your fingers that you've brought this out to length. You'll feel the step deformity is gone. Then your assistant can just come around. If you don't mind coming this way, Jeff, thank you. Then he can just grab, or she can grab from the thumb and two fingers. And when you grab from the thumb and two fingers, you put the wrist in ulnar deviation. If you grab the whole hand, it goes back to neutral. And this maintains radial length, which is a very important part of when you reduce these fractures.
What are the complications of Colles fracture? There might be stiffness, so send the patient for physiotherapy, malunion and cosmetic problems, send for GP or orthopedic team. Reflex sympathetic dystrophy or pseudocus dystrophy, sent for orthopedic carpal tunnel syndrome. It may happen after Colles fracture, but also check the original X-ray because it might be a lunate dislocation. Extensor pollicis longus rupture. This is also might happen after some weeks after the fracture. The patient cannot extend their thumb. This is also a complication of Colles fracture. Smith fracture is when the distal radius is volarly displaced. So it displaced to the volar. In the Smith, it displaced to the dorsal. So there will be volar displacement of the distal part. It is an unstable injury. It requires operative fixation. So place the patient in volar/POP and refer for reduction. We have Barton's and reverse Barton's fracture. What are these? These are also fractures of distal radius, but they involve the articular surface. So it is intra-articular fracture. So in Barton, there will be intra-articular movement and the fracture part displaced dorsally, while the other one displaced ventrally. So both of them, they need orthopedic follow-up and treatment because it needs operation. For example, let's collect all this in order not to mix between them. So we have Colles, in which there is dorsal displacement of the distal fragment of the bone. So this is Colles fracture. There is dorsal displacement of the distal part. We have Smith fracture, volar displacement. So which one is this? This is volar displacement of the distal part. We have Barton fracture. So the Barton, there will be dorsal displacement of the articular fracture. Here there is articular fracture and dorsally displaced. And volar is called the reverse Barton, in which that part which is fractured and including the intra-articular region is displaced to the ventrally. So in summary, only the Colles fracture usually can be managed by in the emergency department. Others better to be consulting orthopedic and doing surgery or doing reduction by themselves. We have something else called isolated radial styloid fracture, also called Hutchinson fracture, in which there will be just a part of the radius styloid fractured. It does not need operation usually. You just need back slab POP and elevation sling, then refer for the fracture clinic or for orthopedic for follow-up. We have triangular fibrocartilage complex injury, also called TFCC injury. This is involve the damage to the structures that stabilize the ulnar side of the wrist and cushions forces between the small bones in the wrist and the ulna. The TFCC injury can occur due to a fall on the outstretched hand or repetitive wrist motions, especially twisting or sudden heavy lifting. The key symptoms for this is usually pain on that side of the wrist or the ulnar side, especially when the patient rotates the hand and also during grip strength. And sometimes there is a clicking sensation. The treatment usually involves the rest splinting of that part of the hand. So you do a back slap for them, giving painkiller, rest, and physical therapy. In more severe cases, it needs follow up by the orthopedician. They may do an MRI, and rarely it needs surgery. Rupture of wrist and hand tendons. The most common rupture involves that tendon which is called extensor pollicis longus. The extensor pollicis longus can be injured or ruptured a few weeks after a undisplaced fracture of distal radius, example Colles fracture. And the patient cannot extend their thumb. You have to refer such patients to the orthopedic doctor. We have radial tenosynovitis or intersection syndrome, also called decurvent syndrome. In this one, there will be fusiform swelling that develops of the radial aspect of the distal forearm. These patients have pain on extension of the thumb, so it needs wrist splint and non-steroidal anti-inflammatory drugs for 7 to 10 days. For non-steroidal anti-inflammatory drugs that can be given, we may give celecoxib or itracoxib or meloxicam. These types of non-steroidal are called COX-2 inhibitors. They are less likely to be associated with GI upset and GI bleeding and have more powerful anti-inflammatory effects compared to the COX-1 non-steroidal anti-inflammatory drugs. For example, diclofenac. Also, we have ibuprofen. We have naproxen. Tendon sheaths of the abductor pollicis longus and on extensor pollicis brevis will be involved. So abductor pollicis longus and extensor pollicis brevis will be involved in decurvent tenosynovitis. As you said, there will be pain on ulnar movement of the wrist and when the thumb is clenched in a fist. For ulnar fractures, ulnar shaft fracture, if it is isolated ulnar shaft fracture, put the patient, if it is undisplaced, just put the patient in above elbow POP and refer for the orthopedic team after 2 weeks. If it is displaced, refer for open reduction and internal fixation. If there is a fracture of both the radius and the ulnar shafts, send the patient for POP and then refer for open reduction and internal fixation, or sometimes the orthopedician may do reduction in the emergency department, closed reduction. We have two commonly mentioned fractures called Galeazzi and Montigia fracture. In the Galeazzi, there is fracture of the shaft of the radius and dislocation of the distal radio-ulnar joint. So it is fracture of the radius, the shaft, and dislocation of the radio-ulnar joint. Montigia fracture, however, is fracture of the ulna and there will be dislocation of the radial head. The proximal part of the radius will be dislocated. So both of them need above elbow back slap and refer for open reduction, internal fixation. It cannot be managed in the emergency department very well. Most of them, they are unstable fractures and cannot be cannot be well treated in the emergency department. The Montigia fracture is medial. The medial bone is the ulna, so there is ulnar fracture, just to remember that. We have also this called Magar. In Montigia, MU, is a proximal bones affected proximally, and the ulnar fracture with dislocation of the radial head. In the Galeazzi, Z is for distal, bones affected distally. This minimum just to remember, otherwise you can memorize it. Buccal fracture. In the buccal fracture, it is not a true fracture. It is just a bump, a raise in the cortex of the bone. It happens in children. There will be pain and very mild swelling. You have to put a back slab or doing just a wrist spling. If you put the back slab, it should be below the elbow. No follow-up needed. Just give painkiller and after 2 weeks remove the splint or remove the back slab. Coming to the elbow injuries, you have to do x-ray of patients who cannot fully extend the elbow and cannot flex their elbow to touch their shoulder tip. So do the x-ray for those patients. Many times you see a normal x-ray. To see the abnormality, let's look for these things which is called anterior and posterior fat pad. So do you see these black areas? The anterior fat pad is usually a normal finding, while the posterior fat pad, it's usually abnormal. In children, if you see a posterior fat pad, it may indicate supracondylar fracture. In adults, if you see a posterior fat pad, it might be due to radial head fracture. Coming to the radial head neck fractures, if the radial head is fractured, if it is undisplaced, it is less painful. Just put the patient on collar and cuff sling, or put the patient in arm sling in order not to move that part, and the fractured part will heal by itself. If the patient is having severe pain, immobilize it in an above elbow POP back slap. So back slap for those patients who have severe pain at a 90 degree. No follow-up is required because most of them will heal by themselves and no need for follow-up. But if it is displaced or comminuted like this patient, it needs orthopedic follow-up. Coming to supracondylar fractures, it is most commonly happening in children. So it leads to fracture just above the elbow, just above the condyle. This is the condyle. Just above it, it is supracondylar region. The typical mechanism of injury is when the patient is falling on an outstretched hand with the elbow is extended. This will lead to driving of the force backward into the distal fragment. These fractures are usually associated with injury to brachial artery. So you have to carefully examine the brachial artery pulsation because if it is injured, it will lead to compromising the blood flow, leading to possible ischemia of the limb. The nerve injury which is commonly injured may be a median nerve. So median nerve injury might happen with that, and sometimes anterior interosseous nerve also frequently involved. Supracondylar fractures are classified by a classification called Gartland classification. In Gartland classification, three types: type 1, 2, and 3. In type 1, it is non-displaced. In this one, you just put in back slap and send the patient for follow-up next week in the orthopedician. In type 2, there is displacement with an intact posterior cortex. So the posterior cortex will be intact in that patient. In type 3, there is complete displacement with no cortical contact, no contact between the cortex. In the emergency department, immediate management includes immobilization in an above elbow back slap. So you put a back slap above the elbow, and this is to stabilize the fracture and prevent its further displacement. Then after that, you have to consult the orthopedic for closed reduction or for possibly open reduction and internal fixation. Pulled elbow is a very common presentation, happens in children. This is due to displacement of the radial head in the annular ligament. So there is a ligament called annular ligament. The radius will be displaced or slipped at that ligament. Sometimes the ligament might be torn. So the patient is having pain and does not use the hand. Usually the mechanism of injury is when lifting or swinging their arm by their hand. As we said, there will be partial displacement of the radial head in the annular ligament. The management involves a reduction procedure which is very easy to reposition the radial head. This will be involving the you do a very mild traction, then you do supination, and then flex the arm. That is all what needed. And sometimes even you may do, instead of supination, you do a traction, then instead of supination you do pronation and then flexion. Both can be successful. Call it hyperpronation. There is also another name for that, call it Nursemades elbow. It is a very common one. All of you can reduce these type of fractures. No need for x-ray, or even if you send for x-ray, it would be normal. The fracture is usually diagnosed clinically by history. Olecranon fractures. The olecranon fracture, if something happens like that, you have to do an above elbow back slap and at 90 degree. If it is displaced or involving the elbow joint and have multiple fragment, you have to do open reduction, internal fixation. Send the patient for orthopedic. If it is undisplaced, just follow up in the fracture clinic or in the with the orthopedician. Dislocated elbow. The dislocated elbow can happen. It is not very common, but the most common injury, if it happens, it leads to ulnar nerve injury. You have to reduce under conscious sedation. To give a very good painkiller, example, a very good sedation like ketamine. Immobilize the arm in an above elbow POP back slap after that. How to reduce it? You have to do flexion at 60 degree, then someone do traction on the arm and someone do a downward traction on the forearm. If reduction is successful, consider for admission because of possible ligamentous injury around the joint. If reduction is not successful, you have to manipulate it under anesthesia. We have shaft and neck humerus fracture. The shaft of humerus fracture can be complicated by radial nerve injury because there is a groove here which contains radial nerve. If it is injured, it leads to wrist drop. This type of fracture, if it is non-displaced, you just put the patient in U-shaped slab like this. So this is U-shaped slab. or also there is another type called hanging slab, and above elbow until it reaches that area. This, with the gravity, it reduces the fracture, it heals the fracture site. If it is displaced or comminuted or angulated, or there is evidence of neurovascular compromise, you have to call the orthopedician. Rupturing of the long head of the biceps, the characteristic abnormal shape and low biceps bulge will happen above the elbow on the attempted elbow flexion against resistance. So initially you have to give analgesia and doing an arm sling, and then later on send the patient for exercises. Surgical repair is rarely indicated. We have tennis elbow. We have two terminology: tennis elbow and golfer's elbow. Tennis elbow is when there is lateral epicondylitis. So this is the lateral epicondyle. All the extensor muscles are attaching to this epicondyle. So with the repetitive use and with abnormal use, it leads to inflammation of that part of that epicondyle of that tendon insertion. So on dorsiflexion of the pronated wrist, it will lead to against resistance, will reproduce the symptoms. So if the patient have dorsiflexion and against the resistance, it leads to, in a pronated hand, it leads to pain. What's the treatment? Non-steroidal anti-inflammatory drug, especially COX-2 inhibitors. Sometimes ice application is also helpful. Support the arm in a broad arm sling and advise the rest. Medial epicondylitis, golfer elbow, there will be the flexor tendon is attached to the medial epicondyle, so that attachment surface will be inflamed when doing specific movements. When the patient is having supinated wrist and you do a flexion, it will lead to reproducing of the pain. Treat as for lateral epicondylitis with non-steroidal anti-inflammatory drug, arm sling, and rest. Olecranon bursitis. We have non-infective bursitis, example gout bursitis. You treat it with non-steroidal and broad arm sling. If you suspect bacterial infection, give antibiotic. Send for orthotin for drainage. Olecranon bursa hematoma, sometime with trauma, could happen, leading, especially with blunt trauma, and there will be a ball-sized one, hematoma forming. Send for orthopedic. Usually treatment is conservative because attempts of drainage of that hematoma leads to secondary infection. Anterior shoulder dislocation. Anterior shoulder dislocation is very common. The injured arm is abducted, so the patient will be having some abduction of the arm and external rotation. There is a step of deformity. In which you do not feel the head of the humerus. Humeral head may be palpated anterior-inferiorly, at the inferior part, because it goes inferiorly to the glenoid. This is glenoid, so it goes inferiorly. The common injury that happens is axillary nerve. The axillary nerve supplies that part of the arm called regimental badge area. The regimental badge area, there will be absent of the sensation. Sometimes also it may involve axillary artery, brachial plexus injury, but this is rare. The treatment of anterior shoulder dislocation is reduction in the emergency department and then put it in an arm sling, then orthopedic follow-up, especially those with repetitive shoulder dislocation, because the joint become very loosened and it may dislocate easily. I will show you a video about how to reduce the anterior shoulder reduction, but let's talk more about it because sometimes there might be associated greater tuberosity fracture. If it is a small fracture, you just go ahead and reduce the shoulder. But if it is a large or complex fracture and dislocation involving the head, so you have to, or involving the neck or shaft, you have to call the orthopedician for reduction. Common associated injuries to bony injuries to the anterior shoulder dislocation are heel sac and Bankart fractures. Heel sac is the posterolateral humeral depression fracture. So it's just something like that. So this is normal, but this is the formation of that groove will be associated with the anterior shoulder dislocation. In Bankart, there is a tear that happens in the lower rim of the glenoid labrum. And now let us show you a video about how to reduce a shoulder dislocation. We have many procedures many maneuvers to reduce the anterior shoulder dislocation, but the most easily one is called external rotation method. For the external rotation method, the arm is placed in a position of slight abduction and external rotation. So this is often combined with gentle traction. As the shoulder is rotated outward, externally, the head of the humerus can slip back into its socket. We have other methods like Hippocrates method, Simpson method, Cunningham method. In Cunningham method, you may also doing massaging of the some muscles of the shoulder like trapezius, deltoid, and biceps.
Yeah, have a full adduction. Good. Give it a little external rotation. Good. And you're in? I think you're in. All right, you're in.
Posterior shoulder dislocations are less common than anterior one, usually occur due to seizures or after an electric shock. The patient presents with a shoulder that is internally rotated and adducted. If you look at the X-ray on the IP view, it will have a light bulb sign, and there is some distance between the humeral head and the acromia. So if you do a modified X-ray view, which is very difficult to obtain, it leads to a lot of pain. It looks like this. Reduction, you see there is clearly displacement of that joint. Reduction is usually not successful in the emergency department. That's why you have to refer for the orthopedic team. Acromioclavicular joint injury. The acromioclavicular ligament, the mechanism of injury usually fall onto the shoulder. It has different grades, grade 1, 2, 3, according to the displacement. In grade 1, it is minimal separation, only ligaments are involved. In grade 2, there is obvious subluxation, but there is still some opposition of bony ends. In grade 3, complete dislocation of the acromioclavicular joint, indicating rupture of the ligaments. So usually grade 1 and 2 are conservative, grade 3 would go into orthopedic team for operation. Humeral neck and head fracture. So this is the neck fracture. If you see, expect significant visible bruising to appear if there is a fracture extending down the arm towards the elbow. If it is undisplaced, just put it in a collar and cuff and giving analgesia. If it is displaced or comminuted, discuss with the ortho team. Rotator cuffs. So the rotator cuff tendons are supraspinatus, which is the most commonly one that is injured, and we have infraspinatus, subscapularis, and teres minor. So these may be injured and cause difficulty in moving the arm. It has different examination mechanism to know which type of which ligament is injured. But for all of them, there may be decreased range of movement. The patient cannot move as well as previous, and there is weakness, crepitus, feeling crepitus, and also tenderness. You have to support the arm in a broad arm sling and give analgesia. Patients who have significantly decreased range of movement, follow up them in the fracture clinic. Most commonly injured one, as we said, supraspinatus rupture. There is a specific sign for supraspinatus rupture called empty water sign, in which the patient, as if emptying a can of water, and you ask the patient to elevate the arm, he cannot because of pain and tenderness. Scapular fracture is not very common, but it needs a very forceful, powerful mechanism of injury. You just need broad arm sling, analgesia, and follow-up. Usually surgery has very limited role. Carpal tunnel syndrome. Carpal tunnel syndrome occurs when the median nerve is compressed as it passes through the carpal tunnel in the wrist. The main causes include repetitive hand movements, conditions like diabetes, hypothyroidism, wrist injuries, pregnancy. So there are some tendons that run through this space, to this tunnel, which are flexor digitorum profundus 4 tendon, flexor digitorum superficialis 4 tendon, and flexor pollicis longus, which is 1 tendon. So these 9 parts plus median nerve. So if there is pressure, the patient will get symptoms. A common sign to detect carpal tunnel syndrome is the Phalen's sign, in which if you flex the wrist for about 60 seconds or 1 minute, there will be tingling or numbness which occurs at the fingers, especially on the thumb, index, middle finger. This is suggesting carpal tunnel syndrome. So we have also another test, call it Freeland test or Tinel test, in which the clinician sits the patient and starts to press down the area of the wrist that the carpal tunnel is located. So it presses this region, it taps, there will be tingling sensation at the thumb, index, and middle fingers. By this way, it can identify if there is pressure on the median nerve. So usually the treatment starts with pain management and conservative management, and sometimes if not improved, it needs surgery. The nerve injuries in the hand and wrist should be identified by the examining emergency medicine doctor or by the orthopedician. We have 3 main nerves that supply the hand. The sensory level are We have ulnar nerve. The ulnar nerve supplies that little finger and half or ulnar side of the ring finger, and the median nerve, you can feel it on the thumb, index, and middle finger, and the radial half of the ring finger. The radial nerve. So all these would be sensed on the palmar aspect. On the dorsal aspect, if you examine that side, especially the groove between the thumb and the ring, you can feel the radial nerve sensation. So what if there is a median nerve injury? If there is a median nerve injury, there will be loss of sense. So it has the level of the lesion might be at the wrist, the lesion, so the injury occurring at the wrist or at the proximal forearm. If there is at the wrist, there will be loss of sensation of the radial side of the finger. So there will be loss of sensation of thumb, index and middle finger, and half of this finger, ring finger. Apart from that, there will be weakness of the thinner muscles, in which the patient is unable to abduct or oppose the thumb against resistance. If the injury is more proximal at the forearm, there will be also involvement of the wrist joint. So if the wrist joint cannot flex, cannot be pronated very well, it means that the injury is more proximal at the forearm. So this is for the median nerve in short. About ulnar nerve, because ulnar nerve supplies the intrinsic muscles of the hand, both the palmar and the dorsal. So the dorsal one abducts the finger. So if there is involvement of the dorsal muscles by the ulnar nerve, so there will be failure of the patient to abduct their finger. In the palmar one, inside, in the palmar aspect, if injured, there will be failure to adduct the fingers. Another important sign to uncover ulnar nerve injury is forementis sign. This is very important when the patient wants to fix a piece of paper or anything else between their middle finger, their thumb and index finger. So normally there will be no bending of the thumb, but if the thumb is bended, it means that there is ulnar nerve palsy. Coming to the ulnar nerve injury, the ulnar nerve injury can happen at the wrist or more proximal at the forearm. What will happen? There will be loss of sensation of the little finger and also ulnar half of the ulnar half of that finger, of ring finger. There is also weakness of the hypothenar muscles, in which the little finger is usually involved. It will be failed to abduct, flex, or oppose the little finger. If it occurs in the forearm, there is weakness of the interossei muscle, in which the patient unable to abduct or adduct the fingers, because, as you said, it's involved in the interossei muscle. Radial nerve injury. If there is a radial nerve injury, there is loss of sensation over the dorsum aspect of the hand, and there is no motor. Of course, there is no motor branch in the hand, but a more proximal injury can result in weakness of the wrist extension. So there will be wrist drop. Let's come to the lower limb injuries. Avulsion fractures around the pelvis. We have anterior superior iliac spine. It is the attachment of the muscle is rectus femoris muscle. The anterior superior iliac spine, also sartorius muscles attached to it. Anterior inferior iliac spine, as we said, it is connected to the rectus femoris. Usually, when there is forceful contraction during activities like sprinting or kicking. So, if you are kicking a hard object, the muscle pulls on the bone when it attaches, then it causes a fragment of the bone to be detached. In the anterior superior iliac spine, this one is attached to the sartorius. This can occur during activities or sudden movements like jumping and rapid changes in direction. So the mechanism of both of them, they are the same as there is rapid or powerful movement that lead to powerful contraction that pulls the muscle and causing fracture. In both of these, the treatment usually is conservative. You have to refer for the orthopedician. And we have ischial tuberosity. The ischial tuberosity is attached to the hamstring muscle. So strong contractions like sprinting or jumping can lead to hamstring, which pulling on the ischial tuberosity. So this lead to an avulsion fracture and can be conservatively treated. There are usually no intervention, treated by rest, analgesia, and follow up by the orthopedic team. Coming to the hip dislocation, when the hip dislocates in its space from the acetabulum, usually there will be sciatic nerve damage. So sciatic nerve damage is possible. How to examine? Try to ask the patient to dorsiflex the foot. If fail, it means drop foot. Also examine below knee sensation. The usual mechanism is dashboard injury. Dashboard injury in the car, the knee hits the dashboard and the force transmitted to the hip joint. So what will happen? There will be shortening and internally rotated like this. Shortening of the limb and internally rotated hip, which is flexed and adducted. As we said, it may damage the sciatic nerve. Also, femoral artery might be rarely injured. So you have to reduce in the emergency department if possible under analgesia. If not, refer for the ortho team to do it under anesthesia at GA. If the patient is having prosthesis or if there is a fracture with it, immediately have to refer to orthopedic team to reduce it. Fractures of the sacrum is also rare. It needs a very large force. There will be damage to the sacral nerve roots. When you want to do sensation, there will be loss of anal, decreased anal tone, and lower limb weakness. Also, bladder dysfunction is possible. Fracture of the coccyx is very common, although I put an X-ray here, but academically and practically there is no need to do X-ray because the mechanism of injury and pain in the lower body is usually significantly telling you that this is a fracture. You may do a rectal exam to search for the rectal tear. If there is rectal tear, you need to reduce it. Otherwise, you just need analgesia like non-steroidal or paracetamol plus a donut seat. What's donut seat? This is a seat that has empty center in which there will be, when the patient sits down, there will be no pressure on the coccyx and it will heal after about a month. Hip fractures are common, especially in elderly due to osteoporosis. we have fractures of the head. That area is called neck fracture, and this is greater trochanter, this lesser trochanter. Any fracture in this area called intertrochanteric fracture, and finally the area below trochanter is called subtrochanteric. So we have the head, we have neck, we have intertrochanter and subtrochanteric fractures of the femur. When the patient is having fracture of the neck, there will be shortening and externally rotated shortening and external rotation of the leg. There is a classification called Garding classification to classify the femur fracture neck according to Garden 1, 2, 3, 4. This is the job of orthopedician to differentiate between them. Fractured neck femur. In the fractured neck femur, usually fascia iliaca block or femoral nerve block, if you apply it, it is the best pain management modality. But if not available, you have to give opiates or even paracetamol, and you have to admit the patient for operation. Isolated trochanteric avulsion fractures. So if gluteus maximus is fractured, there will be greater trochanter dislocation. There will be gluteus maximum avulsion. If there is avulsion of the lesser trochanter, this is due to iliopsoas muscle detachment. Shaft of the femur fracture. The shaft of the femur fracture is also common. It usually needs a good force. Up to 1.5 liters of blood may be lost without visible thigh swelling. Usually the most common symptoms are pain, deformity, and swelling, and later complications will be fat embolism and adult respiratory distress syndrome. The treatment, if available, femoral nerve block or fascia iliaca block is the best. You have to put the patient in Thomas splint. This is Thomas splint. With the Thomas splint, you have to put a skin traction and weight to the patient, and also doing some weight like 5 kg or less accordingly. Kendrick, this is Kendrick. This is special device, commercial. It's very good to stabilize the fracture femur until they reach hospital. Call for orthopedic for admission and preparation for operation. Supracondylar femoral fracture. So this is condylus. So above it is called supracondyle. If you do femoral nerve block, it may not be as effective, but you have to put in Thomas split or Kendrick like femoral shaft fracture. Call orthopedic because they need operation. Most of lower limb fractures need operation. Coming to the knee joint. A knee X-ray is only required for patients with knee injury and any one of the following. So we have Ottawa knee rule to do X-ray or not to do X-ray. If the patient is having knee pain and age more than 55, or isolated tenderness over the patella, or there is tenderness over the head of the fibula, which is located externally or laterally, inability to bear weight at least 4 steps, both immediately and in the emergency department. Or if the patient cannot flex the knee to 90 degrees, so then you have to do X-ray. Otherwise, most of it is either a knee splint or tendon injury. Coming to patellar fracture, we have vertical fracture. In the vertical fracture, because the muscle is attached here and attached here, usually there will be no much problem if you put it in a POP back slap, and then orthopedic follow-up. But if the fracture is comminuted like this or transverse, the muscle parts will pull the patella to each side. So you need analgesia, immobilization, POP, then refer for open reduction and internal fixation. Dislocation of the patella. So this is the patella node in its side. How you know that the patella is dislocated on a X-ray? Usually you have to make a line at the condylus. The patella should be at the level of the condyle, so somewhere here. If it goes up that area, it means that it is dislocated. So usually the patient is having severe pain. The treatment involves reduction, so you have to flex the knee at about 60 to 90 degree, then push the dislocated patella to the middle side, then put a knee immobilizer, refer for orthopedic follow-up team, for the orthopedic team for follow-up. Dislocation of the knee most commonly is posterior dislocation. Posterior dislocation of the distal part, usually due to dashboard injury, like that of femoral neck fracture. So there is a risk of injury to the popliteal nerve, which runs exactly here. So popliteal artery or nerve are often injured, or because there is only three compartments in the leg, there might be compartment syndrome. So popliteal injury and popliteal artery and nerve injury are at risk. Simple traction on the limb can correct the deformity. There is no need for much maneuver. Popliteal, no need for specific maneuver. Popliteal artery and common peroneal nerve injury may happen during reduction. Treatment involves reduction, long POP back slap, and then refer for the orthopedic team for surgery or for follow-up. Tibial plateau fractures, the common mechanism is a pedestrian, is someone who is injured after impact with a car bumper. So this is known as a car bumper injury. On the lateral view of the X-ray, it shows some whiteness over here. This is called lipohemarthrosis. Usually it needs surgical repair. On lateral view, it doesn't show anything, but on anterior view, if you see there is a fracture here. Usually it needs surgical intervention. So put the leg in the along above knee POP back slap and then refer for orthopedic team. Cruciate ligament rupture. We have anterior cruciate ligament. Anterior cruciate ligament tear is usually associated with medial collateral and medial meniscal injury. There will be limitation of the movement of the knee. There will be swelling, and if you do anterior drawer test, it's positive. Anterior tibial spine, if it is fractured, it leads to a avulsion fracture. Posterior cruciate ligament tears for the posterior tibial spine. You have to provide analgesia and refer for the orthopedic team to do an MRI and know the exact diagnosis. For the collateral ligaments, we have two ligaments, lateral collateral ligament and medial collateral ligament. Local tenderness will be there with no laxity. So if the patient having just tenderness but no laxity, the patient should be given analgesia and physiotherapy. But if there is local tenderness and the knee is laxing to inner side, you have to give analgesia, use crutches, quadriceps exercise, doing an MRI, refer for orthopedic team. Although MRI may be done only under request of orthopedic team in consultations. If there is a major laxity, you put it in a POP cylinder not to move, and then plan for surgery. Ruptured quadriceps. In ruptured quadriceps muscle could happen. There is complete inability to straighten the leg. There is a palpable defect here. This needs a strong mechanism of injury to refer for the orthopedic team. Ruptured patellar tendon. So again, as we said, patella should be somewhere at this level. When it goes at that level, it means it is the patellar tendon which connects here to here is ruptured. Above it is quadriceps muscle, while in the lower side it is connected to the to that tendon. So complete inability to straighten straight leg raise. There is high riding patella. There is palpable defect. There might be avulsion of the tibial tuberosity. So the tibial tuberosity might be avulsed. You have to give analgesia, above knee POP backstab, and then refer for the orthopedic unit for surgery. Acutely locked knee. The cause may be a bucket handle tear of the meniscus. So a meniscus injury could happen and leading to inability to move the knee, or bulky flap that has dislocated forwards in the joint. A loose body or an anterior cruciate ligament stump may also be blamed. You have to do x-ray to know if there is any avulsion fracture, give analgesia, and do arthroscopy. Patellar and infrapatellar bursitis are also there. The patient having pain and swelling over the bursa. If infected, you may start antibiotic. Tibial and fibular fractures. For the tibial shaft fractures, put the patient in a long POP backslab and then refer for orthopedic team for operation. Rarely they do conservative management, but if it is displaced or comminuted, usually these type of fractures have risk of compartment syndrome. For fibular shaft fracture, if it is an isolated fibular shaft fracture, like this case, I just need short cast and crutches. If it is undisplaced, you have to follow up the orthopedic after 2 weeks. If it is displaced or comminuted, like in this case, displaced and comminuted, you have to refer for operation. A common complication here which occur is a common peroneal nerve injury. Mesonev fracture. What is mesonev fracture? It is fracture of the proximal fibula. Fracture of the proximal fibula. This is one. Plus unstable ankle injury, in which there is widening of the mortise of the ankle on the x-ray. So there will be ligamentous injury, distal tibiofibular syndesmosis. Sometimes there might be associated fracture of the medial malleolus. This is the medial malleolus fracture sometimes. The treatment is, because it's severely painful, you have to reduce it. You have to put some pressure on that side, so reduction and short length splint, and then refer for surgical correction. For pretibial lacerations, usually suturing the pretibial wounds is not usually recommended, as the pretibial skin is friable, and that tension lead to compromising of the wound healing. Steri-strips might be applied with the suturing or with the glue. Achilles tendon rupture. For Achilles tendon rupture, usually this will happen suddenly. There are some drugs that may increase the risk of Achilles tendon rupture, like ciprofloxacin. It's believed They believe that the patient believed that they sustained a sudden blow to the back of the ankle. There is a test called calf muscle squeeze test, or Simon test, or Thompson's test. So this test involves squeezing of the calf muscle. It will lead to foot to do plantar flexion. So there will be flexion if it is an intact tendon. If the tendon is ruptured, there will be no or reduced movement of that part of the foot. So you put the foot in a long leg plaster, and you have to do plantarflexion, and the knee flex it to 45 degree. Young patients and athletes need surgery, otherwise usually the treatment is conservative. The limb positions may be just to remind yourself that in anterior dislocation, the limb position which comes to you is abducted and externally rotated. In posterior shoulder dislocation, it is adducted and internally rotated. So opposite to that. In femur neck fracture, there will be shortening and externally rotation of the leg. While in hip dislocation, there is shortening and internally rotated lower limb with the hip flexed. Coming to the ankle joint, an ankle x-ray is only required if there is pain in the malleolar zone, in the site of the malleoli, and any one of the following. This is also Ottawa rule for ankle. Ottawa rule for ankle x-ray. So the patient have pain in the malleolar zone, and one of these: first, bony tenderness over the posterior margin. This is the posterior margin of the distal 6 centimeter of lateral malleolus, and posterior margin of the distal 6 centimeter of the medial malleolus. So the tenderness over this, and also inability to weight bear both immediately and in the emergency department at least 4 steps. For the ankle fractures, we have, if it is a small avulsed fracture, or even if it is a large avulsion fracture but undisplaced, you may do a below knee back slap and ortho follow-up. So, for example, such a fracture may not need any operation. But if it is displaced or it is bimalleolar, so both malleoli involved, or trimalleolar, so even the posterior malleoli involved, it needs reduction. If displaced, below knee back slap and sent for orthopedic for open reduction, internal fixation. There is a classification called Weber classification of lateral malleolus fracture. For the lateral malleolar fracture, in Weber A, fracture below syndesmosis. So this is syndesmosis is somewhere here. If at this level, below this level, is called Weber A, it is usually stable. If the fracture above the syndesmosis level may be stable or may be unstable, mostly stable. If there is fracture above, so the fracture at the level of syndesmosis is usually stable, but above the syndesmosis is usually unstable. So you have lateral, medial malleoli, and also posterior malleoli. You have to do operation if the three are involved. Coming to ankle sprain, many times there are so many cases presented with specific mechanisms of injury when they hyper twisting of inward. So typically, as we said, it occurs when the foot internally twists, or inversion injury, while the ankle is in its position of the plantar flexion. So this common mechanism usually happens during activities like running, jumping, or walking, and on uneven surfaces. So in this mechanism, there will be rupture of these tendons. Most commonly, this tendon is ruptured anterior talofibular ligament, which connects the tibia to the talus. So there will be torn of this, and there will be swelling and pain and bruising at that side, and inability to move the ankle very well. That if the patient have pain but can move, you just ask the patient to have rest, ice compression, and elevation, with along with physical therapy to regain strength and stability. In more severe cases, when the patient cannot weight bear, you have to put them in a boot or below the knee cast, call it boot-shaped slab. So you put them in boot-shaped slab, and then you may refer them after 1 week for follow-up by the orthopedician team. Coming to the foot X-ray, the Ottawa rule for foot X-ray series is only required if there is pain in the mid-zone of the foot. In the mid-foot zone, and any of the following. So pain here and bony tenderness at the fifth metatarsal. So at the fifth metatarsal, when they fracture it, it will lead to pain. Bony tenderness over the navicular bone, and inability to weight bear both immediately and in the emergency department for stapes. Coming to calcaneus fracture, usually due to falling from height, directly landing on the ground. If a patient with calcaneus fracture comes to you, you have to examine the other joints like knee joint, hip joint, and full series of spine to be examined. Also examine the other foot for calcaneus fracture. You have to admit, you have to give a good analgesia, below knee back slap, giving rest to the patient, and sometimes they need operative management if it is comminuted, displaced, and things like that. Check the other calcaneus, knee joint, spines for tenderness. Before going to the Lisfranc fracture, I have to tell you about this called Bowler angle. This is measured on lateral radiograph of the calcaneus, in which two imaginary lines are drawn. One line goes from the tip of the posterior facet of the calcaneus to the anterior process. The other line passes from the top of the posterior facet to the superior tuberosity. You have to measure this. You have to measure this angle. The normal angle is 20 to 40 degree. If more than this, if it is less than this, there is concern of calcaneus fracture. Another type which is commonly missed injury is called Lisfranc fracture. Lisfranc fracture is commonly missed. There is dislocation and fracture of the tarsometatarsal. So the history usually due to a horse riding or a car tire running on the forefoot. There will be displacement of the metatarsals at their place, so there will be widening of this space. Treatment includes analgesia and a below knee back slap. If there is multiple displaced or dislocated metatarsals, you may need also open reduction and internal fixation. We have isolated avulsion fracture of the fifth metatarsal. This is also common, so there will be fracture of that one. Inversion may avulse the base of the fifth metatarsal by the peroneus brevis muscle. You have to put some pad, then after padding, a crib bandage, or ortho boot can also be applied. Then refer for follow-up. We have Jones fracture. In the Jones fracture, of the fifth metatarsal. Again, there is inversion injury because of peroneus brevis leading to avulsion fracture. The management includes below knee back slap, and also fracture clinic follow-up. Stress fracture of the metatarsals could happen due to prolonged or unusual exercise. Most common site is the second metatarsal. It is usually going unrecognized. You have to have high suspicion to diagnose. There will be localized tenderness of the metatarsal shaft. X-rays are usually normal initially. About 90% of them, they have normal X-ray. But after 2 to 3 weeks, you may see callus formation or periosteal reactions which happen. The treatment is analgesia and orthopedic follow-up after 2 to 3 weeks. Plantar fasciitis is also a very common presentation to everywhere, but this is usually coming to these patients come to GP or to the orthopedic clinic. Gradually, the pain increases in burning pain in the sole of the foot and heel, which is worsened on weight bearing. Usually, the patient have feeling the pain at early morning. When they want to stand, there will be pain starting in their plantar area. There is localized tenderness if you examine over the calcaneus insertion of the plantar fascia and heel pad. The treatment is you have to put a padded sole and also analgesia, non-steroidal anti-inflammatory drug, and specific types of physiotherapy. Sometimes they bring a bottle of cold water and they do rolling movement on it in order to improve. If you have open fracture anywhere in the body, you have to classify it according to the Gastillo. So according to the Gastillo classification of open fracture, we have type 1, 2, and 3. And that of 3 have 3 subtypes, A, B, C. In type 1, there is an open fracture with a wound which is very small and less than 1 centimeter, and it is clean wound. In type 2, there is an open fracture with a wound more than 1 centimeter and not associated with extensive tissue loss, avulsion, or flap, but it's more than 1 centimeter. In type 3, the type 3A, there is extensive tissue loss damage, but there is adequate bone coverage on the by the soft tissue. Or sometimes there is high energy trauma possibly. In type 3B, there is extensive tissue loss with periosteal stripping. So there is also involvement of the periosteum of the bone. In type C, there is fracture, open fracture, associated with arterial injury that leads to bleeding and needs repair. Treatment for open fracture, the first thing is you have to do hemorrhage control by pressure, by bandaging, by tourniquet, then do a good fluid resuscitation, send the patient for investigations, complete blood count, and also RH and blood group and RH, then giving a good analgesia. Take a picture. Why you take a picture? Because you don't want every doctor to open it and look at it when they want to examine, because it leads to infection. If you call the orthopedician and look again and open it, it may lead to unnecessary exposure to the septic environment. Irrigate with saline and then cover with a sterile moist dressing. So hemorrhage control, fluid resuscitation, analgesia, take a picture, then wash it and dress it. The distal pulses should be marked. Give a broad spectrum antibiotic and tetanus immunoglobulin and booster tetanus status should be established. And then referral for the orthopedic team. Compartment syndrome occurs when there is increase in the intracompartmental pressure. It might be secondary to external compressive forces or internal expanding forces. So example of external compressive force when the patient is on a POP and it is tightly it is tightly bandaged, so it leads to compartment syndrome. Internal expanding force, example, there is a big fracture, there is an artery ruptured, or there is a burn, or there is a example electrical burn. So the features are, the first feature, the most important feature to recognize is pain. The pain is out of proportion to the injury. And if you look, the swelling is not too much, but the pain is so severe that sometimes you do not believe that he is having so much pain. But when you do passive stretching of the muscle, it will lead to excruciating pain. There is also paresthesia, so this is the second P. Another P is paralysis, pulseless, pallor, poikilothermia, decreased temperature. All these symptoms might happen late, so try to find the pain which is out of proportion and by stretching as soon as possible. For the compartment syndrome, do an X-ray to know if there is any fracture. You may send urine to check for myoglobin. Our normal general urine examination strips can read myoglobin as RBC, red blood cell. So if RBC is too much pluses, it means it might be myoglobin which misreaded by the general examination strip as hemoglobin. Creatine phosphokinase, renal function test to know if there is involvement of the kidney. You have to measure the compartment by a machine which is most of the time not available, but if available, you have to measure it. It is normally it's between 0 to 8 millimeter mercury. You have to know the difference. If the difference between intracompartmental and diastolic blood pressure is less than 30, it means that fasciotomy is indicated. So the treatment of compartment syndrome is done by the orthopedic team. They do fasciotomy, excision of the dead muscle tissue, and possible amputation if the patient is at risk of getting renal failure. The complications are rhabdomyolysis, renal failure, hyperkalemia, hypocalcemia, hypovolemia, local infection, ischemic contracture like this, called Volkmann's contracture, neurological deficit, limb amputation, and sometimes death. Coming to septic arthritis, usually the mechanism is of getting the infection is by hematogenous spread, which is the most common one. Contagious spread from the infected periarticular tissue like osteomyelitis or cellulitis, and also sometimes direct inoculation when they do an operation or during a penetrating injury. The most common infecting agent is Staphylococcus aureus. Staphylococcus aureus is the commonest overall, but in ages between 6 to 24 months, hemophilus is common. In patients who are sexually active, younger patient, Neisseria gonorrhea is also a common microorganism for septic arthritis. What you do is that you do investigation, you do a joint aspiration and send synovial fluid analysis for wide BC, for culture and sensitivity. Also send for investigations, especially full blood count inflammatory markers like ESR and C-reactive protein. They are very important. You may send for blood culture because they are liable for sepsis. Do an X-ray to know what is the extent of injury or damage. Treatment is IV antibiotic. It may change according to the local policy, but best one is flucloxacillin and benzyl penicillin. and giving analgesia, urgent orthopedic referral. What the orthopedic do? They may do joint irrigation and drainage of that area. There is a criteria especially used for a child with painful hip or painful knee, in which it's called Kocher criteria. The Kocher criteria is very important because it involves four criteria. So the four criteria are non-weight bearing, fever temperature more than 38.5 degrees centigrade, weight white blood cell more than 12,000 per hour cells per high power field, ESR more than 40 millimeter per hour. So if the patient have four criteria, all four criteria are there, it means 99% there is chance of having arthritis or septic arthritis. If three criteria, there is chance of 93% of having septic arthritis. Gonococcal arthritis, as we said, it's usually common in younger sexually active people. It may cause two types of arthritis: a localized septic arthritis that affecting only one joint, or an arthritis dermatitis syndrome. The classic triad is dermatitis like this, tenosynovitis, and migratory polyarthritis. The patient have pain here, then in that knee joint, then in the wrist, then in this joint. The treatment is broad spectrum antibiotics. Coming to another common presentation is gout, although this is more commonly presenting to the GP, but let's have a look. For a gout, usually it involves the big toe, the proximal joint. The causes is due to increase in the uric acid. There is hyperuricemia because of increased production of uric acid by alcohol, high purine diet, cytotoxic drugs, myeloproliferative disorder, trauma, exercise. Sometimes there is decreased excretion of uric acid. Commonly it's idiopathic, but it might be due to some enzyme defects, drugs like diuretic, low-dose aspirin, and renal failure. So in these patients, there will be pain, swelling, limitation of movement. Sometimes it might involve tophi to the ear, to the fingers, toes, and elbows, but most commonly it involves a tarso-metatarsal joint of the thumb. You may send synovial fluid analysis just to exclude the septic arthritis by doing gram stain and culture, but you may find crystals which are negatively birefringent. Do an X-ray to know the extent of the injury, and also about plasma urate level. So the serum uric acid level should not be sent in acute episode. Do not send it in acute because it is usually sometimes normal during acute episode, so you will fail to diagnose the patient. The treatment is non-steroidal anti-inflammatory drug. If the patient not responded, or the patient if the patient have contraindication, you can use colchicine. If the patient not responded to treatment or have contraindication to use this, you can use corticosteroids. Sometimes corticosteroid local injection is also used to treat the gout. We have pseudo gout, similar thing. It involves joint, but usually involves larger joint. Example, knee joint. So you send the synovial fluid analysis, which shows weakly positive birefringent crystals. X-ray may show destructive changes like osteoarthritis. The treatment is usually symptomatic with non-steroidal anti-inflammatory drugs. Usually you refer such cases for orthopedic or for the rheumatology team. So this is a differentiation between the gout and pseudo gout on examining their fluid. This does not need to have so much look, but just to know that of gout is negatively birefringent and that of the pseudo gout is positively birefringent. Ankylosing spondylitis, if the patient is having chronic low back pain, especially in men aged between 15 to 30, younger men, there will be progressive spinal fusion. Usually it is an HLA-B27 related disease. So the joints will fuse. There might be also extra articular manifestations like eye involvement, uveitis, lung involvement, lung fibrosis, aortitis, plantar fasciitis, and Achilles tendonitis. So if you do an X-ray, you may see that there is fusion of the joints. It shows like a bamboo spine. The treatment is symptomatic and you send them for the rheumatology team. Complication is fracture. Reactive arthritis, in previously called Reiter's syndrome. Reactive arthritis, the classic trait is that the patient have urinary symptoms due to arthritis, blurred vision and pain due to conjunctivitis. Also, they have arthritis, swelling of the limb of the joints. The causative agent may be due to chlamydia, shigella, salmonella. Treatment is giving antibiotic and non-steroidal anti-inflammatory drug. I put these nervous and common fractures. So the common fractures that cause the nerve injuries I put here in order to have a look and do not confuse during exams. At the end, it was a very long lecture. I hope you get benefit from it. You may take more information if you are in the emergency department and see the patients during actual treatment. But most of the patients, when they come to the emergency department and they have a big trauma, they need also police paper. Don't forget police paper because they have medical legal issues, even if they don't ask for the police paper. And at the end, I want to thank the housing organization for education and development because they organized it and they did the PowerPoint issues for me. This is under supervision of Hawler Medical University and in collaboration with the Kurdistan Society of Emergency Medicine. Thank you.